everyone. So in this particular video, we are going to be talking about pineal tumors. This is a very important topic as far as the cases are concerned. So anybody who's dealing with a lot of brain imaging, this is an important topic about that. So first, I'm going to start briefly with the anatomy of the pineal gland. So the reference for this talk is primarily Osborne. That's what I've done for almost all neuro classes. So same goes with this one. So these are two beautiful schematic illustrations from Osborne. So this is where the pineal gland is located. This, as you all know, is the third ventricle. So pineal gland is a small gland which secretes melatonin, which is situated in the posterior wall of the third ventricle. So now what you need to know about the relationships here and what is important to us for the imaging anatomy, I'll give you a mnemonic which will come in very handy. So you want to remember famous VIP. Yeah, so famous VIP is our mnemonic. So from up to down, from superior to inferior, topmost structure is going to be fornix. V is going to be velum interpositum. Velum interpositum is nothing but an invagination of the pia mater. It's actually a space, right? Which I'm sure you know, cavum, velum interpositum can also form if there is expansion and it's filled with CSF. So that's what we call as CVI, just like how we have cavum septum pellucidum. So just like septum pellucidum, it's this invagination. In fact, if you can look here, this is that fold that you can appreciate. So this is that invagination of the pia mater, that is velum interpositum. Then you have the internal cerebral vein. The internal cerebral vein, the two internal cerebral veins are just going to combine to form the vein of Galen. So it is at that precise point where they're going to combine to form the vein of Galen that the pineal gland is situated. So sometimes you'll see ICV in the relation, sometimes you'll see vein of Galen, actually mean the same thing. And then you have P for pineal gland. So if famous VIP sorted, just twist it a bit. So above and below the pineal gland, you have two commissures. Okay, so once I have famous VIP down, now up and down pineal, you want to remember HP. So just superior to it is the habenular commissure and just below it is the posterior commissure. And it is because this posterior commissure is so closely related to the pineal. For example, if this is the pineal, this is where you have the posterior commissure. And that is why you have Parinod syndrome. You know, Parinod syndrome is a vertical gaze palsy, and this is the center. It's this vertical gaze center, which is posterior commissure, which is so closely related to it, right? So just on the schematic now, let's follow our famous VIP. So this, as you know, is the fornix. You have the velum interpositum here, which is that empty space. You can see the internal cerebral vein here, and this is pineal gland. So this is habenular commissure, this is posterior commissure. So famous VIP, and then up and down, P ke upar niche, we have HP. This, as you know, is the tectal plate. Okay, so this is the tectal plate. This is the midbrain. This is the aqueduct. So this is what we already know. From a coronal point of view, again, you can see the two internal cerebral veins, which have to combine to form the vein of Galen here. And this is the velum interpositum, where you have the pineal gland. Okay, so this is how it's arranged in the coronal view. On the sagittal MRI, so you can see the corpus callosum. This is the fornix. So you can see the fibers of the fornix here. You can see the internal cerebral vein, which is coursing, and it continues to become the vein of Galen at this point. So this is famous VIP. So this is the internal cerebral vein. The curved arrow here shows this empty space, which is velum interpositum. And this is where we have our pineal gland. So pineal gland, you don't really need to know the dimensions per se, but just remember that anything less than 10 millimeters is normal, right? So in the height, 10 millimeter height, anything less than that is normal. So this is what we need to remember here. From a coronal point of view, again, you can see the fornix here, the two fibers fornix. You can see the flow voids of internal cerebral vein, and this is the pineal gland. Okay, so this is what we need to know about the anatomy from this point of view. Approach to pineal lesions are pretty simple. Essentially, any mass in this lesion is either a pineal gland mass, or we call it a pineal region mass. So either it originates from pineal or its surrounding structures. So essentially what the pineal gland is made up of is just the pineocytes. The pineocytes are the cells of the pineal gland. So either you have a pineal parenchymal tumor or you have germ cell tumors. Now, germ cells are not normal constituents of the pineal gland. It's been hypothesized that they migrate here. Okay, so in cases of germinomas, there are two theories. One is that germ cells migrate here and then you have germinomas. And the second theory is that there are pluripotent cells which then become, into germ cells. So the pluripotent cells turn into germinomas. So that is what the hypothesis is. So pineal gland mass is either a primary pineal parenchymal tumor, that is what we refer to as a PPT, so pineal parenchymal tumor, or a germ cell tumor, or it can be anything else, which can be any brain tumor, so an astrocytoma, oligodendroglioma, meningioma, something that can exist anywhere else can come here as well. So this is what we need to know as far as the pineal gland mass differentials are. As far as the clinical features are concerned, because it's in the posterior wall of the third ventricle, it can block the third ventricle, resulting in hydrocephalus, which is the most common presentation. As we discussed, posterior commissure and tectal plate compression can lead to Parinod syndrome, which is the conjugate vertical gaze palsy. There will be convergence failure and blepharospasm, all of which because of the posterior commissure compression. A very rare symptom is a sudden presentation of shock. So just how we have pituitary apoplexy, if there is bleed into a pineal gland mass, then what we have is a pituitary or a pineal, in this case, pineal apoplexy, which looks something like this on a CT scan, where you can see that there is a mass lesion with calcification, and then you have the sudden development of a mass lesion, which is big in size with the presence of hemorrhage, right? So bleed into a large pineal mass, frequently seen with germinomas and pinealoblastomas because they are hypercellular necrotic masses. So these are the ones which can develop these bleeds called as pineal apoplexy, right? So now let's get back into our approach. So whenever you have a pineal gland mass, we have to decide out of these differentials. When we talk about a pineal parenchymal tumor, they constitute approximately 30% of the pineal gland tumors. Germ cell tumors are the most common at around 40% prevalence, and the remaining 20 to 30% are going to be the other lesions like lipoma, meningioma, epidermolysis, astrocytomas, all of the miscellaneous ones. Metastasis, very, very important. So this is what constitutes the others. Now let's go inside PPT. So PPT meaning pineal parenchymal tumor. Here further we have three things that you have to remember. The most well differentiated is what we call as a pineocytoma. So pineocytoma is your very well differentiated grade 1 tumor. Then what we have is PPT-ID, pineal parenchymal tumor of intermediate differentiation. So intermediate, not WHO grade 1. It says grade 2 or grade 3. Okay, so this is grade 2 or grade 3. So pineal parenchymal tumor of intermediate differentiation, and WHO grade 4, most aggressive, as you all know, is pinealoblastoma. Okay, so pinealoblastoma is your WHO grade 4 tumor. So these are your three PPTs, pineal parenchymal tumors. Here, the most common one, which is around 65%, is going to be PPT-ID. You have around 20% of pinealoblastomas and remaining 15% of pineocytomas. Okay, so PPT-ID is the most common. So here we have our three DDs, and it is pretty clear when we look at the imaging that the aggressiveness of the lesions will increase here imaging wise. So we have a fair idea of what each one of them looks like. Then you have germ cell tumor. Now, most common germ cell tumor is going to be germinoma. So germinoma is your most common, and so this constitutes 2/3 of these germ cell tumors. And then what we have a category of miscellaneous germ cell tumors, which are called as non-germinomatous germ cell tumor. Just how we have non-seminomatous in testis, this is where germinoma is most common. So the other 1/3 belong to non-germinomatous germ cell tumor, which are your other lesions like choriocarcinoma, yolk sac tumor and stuff. Others, the most common is metastasis, and then we have others that we will look at. So this is what essentially we have to do. Mainly these 4 lesions, we are going to see the imaging patterns, and we'll look at some other differentials as well. What really helps here, in apart from the imaging features, in differentiating them, is the age of the patient. So there is a clear-cut demarcator wherein these are present in middle-aged patients, whereas pinealoblastoma and germinoma are present in younger adults. So pineocytoma, PPTID usually in middle-aged adults, whereas pinealoblastoma, germinoma in younger patients, germinoma particularly in adolescents. Okay, so that's important. CSF oncoproteins, meaning your tumor markers, become very, very handy in the diagnosis of germinomas and other germ cell tumors. So that again favors. Another thing which may favor a diagnosis is that if you have a pineal plus a suprasellar lesion, if 2 coexisting lesions, it's likely to be a germinoma, which can be present in 2 locations. If there is a pineal mass with CSF spread, that favors the diagnosis of a pinealoblastoma. It may also be seen in germinomas, and it may also be seen in metastasis. So when you have CSF spread, these are the 3 main DDs that we have to